Good afternoon. I'm going to call this In the Office. Periodically, I'm going to make quick videos of interesting cases that I see in the office. Here I saw a 35-year-old woman who was transitioning to a new doctor, which was me, and a history of hypertension. And she's on labetalol, 100 milligrams once a day. That's it. No other past medical history. And her blood pressure was 200 over 120. Very concerning. And she claimed compliance with whatever she was on. So what to do? What I did initially, started her on amlodipine, dihydropyridine, calcium channel blocker, 10 milligrams a day. And olmesartan, an ARB, 40 milligrams a day. And I upped the labetalol twice a day. Did not want to stop it. I did not want her to go into beta blocker withdrawal. Got blood work on her. And of note, and she's not on the diuretic, her potassium was 3.4. So what I did, I was able to get the lab to run a renin and aldo level on her, and they were pending at her next visit. On the 12th, her blood pressure was 160 over 115, certainly very elevated, but it did come down. And I added spironolactone 50 milligrams a day. And then the blood pressure did come down to around 130 over 90. Blood work showed an aldo level of 21, and renin was really suppressed. Her renin level was 0.8. So the purpose of this lady has primary aldosteronism. That's what's causing her hypertension. She does not have essential hypertension. And this is stuff that they're reporting more and more of, that this exists. And certain recommendations, recommend that you screen everybody for this. This woman had a low potassium. A lot of these patients don't have that. I got her on an aldo blocker, and I got a CT of her abdomen, and lo and behold, she has a left adrenal nodule, 15 millimeters. Most likely an adenoma as per radiology. So what needs to be done here? You just don't take this out. She's going to need to go to interventional radiology, and they're going to need to get sampling from both adrenal veins to see if this lateralizes. And if it lateralizes, she's got a lot more aldo secreted from one adrenal compared to the other. Then she'll get surgery, she'll get an adrenalectomy, and her blood pressure will go down. And she may need medications, but she's not going to need 4 medications. The purpose of this brief video was to make people aware that this exists, and you got to think of it. Now, this patient was somewhat easy because her blood pressure was sky high and her potassium was low and it was unprovoked. But a lot of these people have normal potassium. And that's all I have to say here. You got to think about primary aldosteronism. Done.